أقفل الشبكة. بسم الله الرحمن الرحيم. أبنائي وبناتي طلاب جامعة جوبا، جامعة بحري عفوا، إنما ناس قدام يا أولادي معلش من أيام جامعة جوبا. Today we are going to continue our talk about HIV. As I said, HIV now is very common infection in our country and in Sudan in general. Pulmonary involvement is among pulmonary infection is among the most common infection in HIV patient. Bacterial pneumonia and tuberculosis occur early in the course of HIV. Pneumocystis carneae pneumonia almost always occur when the CD4 count becomes less than 200, while toxoplasmosis and cytomegalovirus infection and Mycobacterium avium complex infection usually occur when the CD4 count is less than 100. In advanced stage of the disease, more than one pathology may occur. As you know, if a patient has severe pneumonia, usually he will have fever, shortness of breathing, pulse rate more than 100, fatigability and lethargy, not able to walk and unable to talk, and usually he will have severe chest pain. And in less severe pneumonia, fast breathing, night sweats, and chest pain. Possible, and if there is this is the most common presenting symptom. In differential diagnosis of chest infection HIV patient, Mycobacterium tuberculosis and Mycobacterium avium is common one. Also, the patient may have toxoplasmosis, or he may have bacterial infection like Streptococcus pneumonia and Haemophilus influenzae, and fungal infection like Pneumocystis carneae, and helminthic infection like Staphylococcus stercolis. Also, the chest may be involved by viral infection like cytomegalovirus, or malignancy like lymphoma or Kaposi sarcoma, and other. The patient also may have aspiration pneumonia. Early on, when the CD4 is high, more than 200, the patient is susceptible to TB. When the CD4 becomes less than 200, the patient is susceptible to Pneumocystis carneae pneumonia. And when the CD4 less than 100, the patient is susceptible to more protozoal infection like toxoplasmosis, Mycobacterium avium complex, and cytomegalovirus infection. This bacterial pneumonia, you can see this non-homogeneous consolidation of the left upper middle and lower zone. And etiology, the common etiological agent is Streptococcus pneumonia and Haemophilus influenzae. Clinical presentation usually of bacterial pneumonia is abrupt chest pain, fever, chills, rigors, and productive cough. with shortness of breathing, tachypnea, and pleuritic type of chest pain, like any type of pneumonia. A recommendation, usually will find infiltrate in one lobe with air bronchogram. More infiltrate, more diffuse infiltrate in case of influenza pneumonia, and bilateral patchy consolidation in very ill patients like in Staphylococcus aureus pneumonia, and upper lobe consolidation and cavitation. Often we don't go for sophisticated investigation like CBC, gram, stain, and so on. Chest X-ray is quite enough. Also, now recently we can do gene exhibit for tuberculosis. This slides, we are going to overview this slide in individual one. Diagnosis. In practice, the diagnosis of bacterial pneumonia will often be made based on the initial clinical presentation and maybe by chest X-ray and the Helsing staining, and as I said, by gene expert for tuberculosis. To prevent pneumonia, usually we give co-trimexazole, that is ceftriaxone, which will prevent pneumonia and or even it prevent diarrheal disease. If there is no BCP, you can give amoxicillin for treatment of mild to moderate pneumonia, and in severe pneumonia you may give ceftriaxone injection. If you suspect Staphylococcus aureus infection, you should add coloxacillin 1 to 2 grams every 4 hours. Nocardiasis. This is a fungal infection that occurs in the lung, very rare in immune competent patients, like it may occur in an immune incompetent, which look like tuberculosis. It can affect the upper zone and cause cavitation and fluid level, and gram stain is positive, often associated with multiple abscesses, not just in the lung, in the brain, and in the skin. Also, nocardia, you can see this nocardia on microscope examination, and the treatment is with co-trimexazole. Acute respiratory illness in HIV patient is accompanied with usually high fever and chills, and should be treated as emergency. Co-trimexazole, that is ceftriaxone, reduce the incidence of bacterial pneumonia like Haemophilus influenzae, Streptococcus pneumonia, and Staphylococcus aureus. Pneumocystis carinii pneumonia. This is a very common infection in HIV patients, especially those with CD4 less than 200. Etiology is usually by pneumocystis carinii, activation of already infection or new infection. Clinical presentation usually dry fever and progressive shortness of breathing. العيان يقول لك أنا ما بقدر أمشي مسافات طويلة, and fever and over 1 or 2 weeks, and tachypnea and tachycardia. and this is the PCP under microscopic examination. Usually in the X-ray you will find bilateral infiltrate beginning in the prehilar region and or ground grass appearance, and 25% normal as the initial presentation. PCP may be associated with pneumothorax. Can also present with more infiltrate like this. Cotrimazole is the treatment of choice in a very high dose, 20 over 100 milligram per kilogram body weight per day in divided dose, 4 doses. Usually in adults this is very high dose. as you know سبترين دايما بندي 2 tablets بيدي أو حبتين صباح مساء. In BCB we give 4 tablets every 6 hours, 4 حبات كل 6 ساعات. Also because the patient is tachypneic, you need to give oxygen, fluid, and the patient will get dehydrated, you need to give fluid. Steroid is very crucial in BCB, and usually you give in a dose of high dose and then taper over 22 days, 21 days. Pentamidine is alternative treatment for PCP, but usually is very expensive and not available in Sudan. Trimethoprim 15 milligram per kilogram body weight, and Dapsone is an alternative also treatment. Clindamycin 600 milligram IV 8 hourly plus primequine is another alternative. Usually the patient will be better after 1 week. If no improvement, suspect another infection. PCB co-infection with other here, PCB with histoplasmosis or cryptococcosis. Here PCB with TB. Cotrimazole is a prophylaxis, is usually is very effective prophylaxis in reducing the incidence of PCB. Kaposi sarcoma is very also common in patients with HIV and usually can cause bloody blue effusion, as you can see in the right lung. The fungal infection also in common in HIV patients like histoplasmosis, coccodomycosis, and aspergillosis and cryptococcosis. TB HIV should usually be linked together. Any patient who is HIV positive should be screened for TB, and any TB patient should be screened for HIV. A study in some part of sub-Saharan Africa, including Sudan, showed that HIV seroprevalence among TB patients is 70%, and a limited study in Haiti, 29%. TB staging. TB can appear at any stage of immunity, but currently classified at stage 3. So any patient diagnosed with TB, he should be considered as stage 3 HIV. Diagnostic channels, usually the cough is less than 3 weeks. Any cough more than 4 weeks should be suspected. Any patient who has cough more than 3 weeks in HIV patient should be suspected to have TB. So any cough, HIV patient with cough more than 3 weeks should be considered as TB, especially if it is associated with weight loss. Hemoptysis is less common in HIV patients. Also, the chest pain is less common, and shortness of breathing, and fever. Diagnostic test is the nursing style of, but this, as you know, is time consuming and it may take 24 hours to yield the result. So nowadays the recommended test is gene expert. So we do gene expert for tuberculosis. This is now is the gold standard test. Early on, the patient may have typical presentation, as you can see in the X-ray, affection of the right upper zone with cavitation, but later on, when the CD4 count become less than 200, the patient will have atypical presentation and extrapulmonary tuberculosis. Presentation depend on the stage of HIV. So if the patient is stage 1 and 2, he will have hemoptysis, cough, night sweat with weight loss. But if the patient have stage 3 and 4, he will have fever, dyspnea, and weight loss. And the smear often negative. In stage 3 and 4, but positive in stage 1 and 2. X-ray, usually the patient will have cavitation in stage 1 and 2, and while in stage 3 and 4, the patient will have lower zone infiltrate. Sputum and gene expert for tuberculosis. Here you can see the acid-fast bacilli in the nursing staining, but now this is obsolete. We do gene expert. Within half an hour you will get the result. The patient is have TB or not. This is the case of pulmonary tuberculosis.
Allahu Akbar, Allahu Akbar, Allahu Akbar,
Allah. You can see here the refill filtrate. Allahu Akbar. You can see now the patient has infiltrate. Here patient with PCB and TB. The mortality in TB HIV infection is very high. Reinfection or recurrence of TB after the treatment in HIV is very high. For so any patient who have TB and receive treatment and he has relapse or recurrence, you have to suspect that this patient is HIV positive. So, in patient with recurrence, in 16% you will find that the patient is HIV positive. Here, hilar lymphadenopathy, patient with HIV TB with pericardial effusion. Here, patient with a pleural effusion. Thank you. كده وصلنا لنهاية الTB and HIV. there is next slide بحاول أنتزع لكم السيشن الجاي اللي هي عن التريتمنت of TB. طبعا أي question in TB treatment if you didn't answer it, it will be fatal. So the treatment is the dot treatment, combination, fixed dose combination. That to say, a tablets which contain rifampicin, INS, pyrazinamide, and ethambutol. 4 drugs: ethambutol, rifampicin, INS, and pyrazinamide. So you have to go and read about anti-tuberculosis.